start now. We can't wait for the people who have been waiting here. And you have been honest and sincere on time. So we can't make them suffer. So we'll start the class. Okay? So we have today, now this week's session is on respiratory care. So most of them, I mean, as you all know, after the COVID period, we have all realized it's very important for us to have ICU setup. And most of the hospitals, they have increased their ICU beds, including NIMS Hospital. And you might be knowing that this fifth floor, while coming also, most of the beds are ICU beds and ventilator. And ventilator is like management, you should, as a nursing staff, you should always know. And in fact, you will be shifting from one place to another place. So, and being in nephrology, you know how like patients, they just collapse and they need to be intubated at every time, even the wards. And of course, ARs in the high, acute care, and most of the patients are ventilators. So this is a basic thing for all of you. Even if you are posted in the wards, you are supposed to know this, upgrade this. So we have put this in respiratory care in the 1 week program. And I want to thank Department of Anesthesia, Dr. Padmaja Madam, who have helped us in designing this customized program on respiratory care for you people. So today's topic is on intubation kit and emergency medicine, that will be taken by Dr. Pujita, your senior resident. Assistant professor. You're assistant professor of Department of Anesthesia. So,
Good afternoon, respected ma'am, and all dear nursing staff. Today I am presenting on intubation kit and emergency drugs. So first of all, what are the essential components of intubation kit? The essential components are endotracheal tubes, laryngoscope and blades, syringes and medications, stillets, and securing devices and tapes, then oxygen delivery equipment, suction equipment, personal protective equipment, and sterile room cleaning. So whenever we have to intubate a patient, all these checklist has to be there. So first about endotracheal tubes. So this is endotracheal tube. So this is cuffed endotracheal tube which has a cuff and a pilot balloon, and the one which is on the right to it is a non-cuffed endotracheal tube which is used for pediatric patients. So the minimum size of endotracheal tubes is 2.5 size and maximum is 8.5. So for an adult female, we use 7 to 7.5 size cuffed endotracheal tubes, and for adult males, we usually use 8 to 8.5 size cuffed endotracheal tubes. So for other children, it depends. We have to keep both cuffed and uncuffed endotracheal tubes should be there. So the size is important in children less than around 5 kgs. We should be very careful what size of ET tube we are selecting. And when selecting an ET tube, one size more than that patient's weight should be selected, one size plus and one size minus. So suppose if we have to intubate a neonate with 3 size endotracheal tube, we have to keep 2.5 and 3 and 3.5 sizes ready. So for preterm neonate which is less than 1.5 kgs, we have to keep 2.5 size usually ready. Then for a neonate, 3 size. Then a small infant, 3.5 size. Then accordingly with the age, or the simple calculation is the little finger width. So we have to measure little finger with the tip of the endotracheal tube. The size which is equal to our little finger is the size which fits into that patient. That's how we can select an endotracheal tube. And this is the balloon. Once we intubate a patient, we have to put a syringe and inflate with 5 to 7 ml of air in this endotracheal tube. And we have some device which can measure pressure also. So usually that pressure monitor we can use in ICU patients, so that when we have intubated patient for a long time, then it does not cause pressure necrosis because of this cuff inflation. Then laryngoscope and blades. So this is a laryngoscope. This is called as Macintosh laryngoscope blade. Except for a neonate and small infant, for everyone we use this blade which has curve. Macintosh blade. So it has a handle which has got batteries inside. Which has got 2 batteries inside. So once we place the batteries, then only. So this is the handle, this is the hinge. To this hinge, we have to keep this blade and then open it. Then we get a light. Once this light is good, then only we have to use this blade. If this light is flickering or if the light is dim, then we have to change batteries, and we have to not use such a blade for intubation. Otherwise, we can have difficulty while intubation on visualization and all. So there are sizes. So over this blade, here there is a mark written MAC4. So this is a 4 size blade. This one, 4 size blade. This we use for a large adult patient, and extra large patient like who is above 120, 130 patients, 5 size blade also can be used. And for a small child, 1, 2, 3, 4 sizes. For a female, usually we use 3 size blade, and but for a large adult, 4 size. So we have another blade, Miller blade. This is a sharp blade. Actually, this blade has a curve, but for a Miller blade, it is a straight blade. Usually for neonates and small infants, we have to keep Miller blade also ready. For other patients, this size is okay. So this is a 3 size blade, whereas this is a 4 size blade. And this is a 2 size blade. For all the blades, here number is written. Then laryngeal mask airway. This usually in emergency situations and in ICUs, we usually intubate a patient. But when the airway is difficult and we are not able to intubate or ventilate a patient is desaturating, we can use this supraglottic airway, which is laryngeal mask airway. This we need not insert a tube inside cords. It will just sit above a patient larynx. So the method of insertion is just open the mouth, displace the tongue, and place it as when a resistance is offered, and that is the end point. We have to inflate a cuff. This is the cuff. This is the cuff. So the volume, how much we have to inflate, is written above this cuff itself. So the size is around, for a normal adult who is 50 to 70 kg, 4 size will take, and who is around 40 to 50 kg, we use 3 size LMA. And all this, how much we are going to inflate and all this is written over this one, this cuff. Then IGEL. This is much easier and more easier to place than in classic laryngeal mask airway, because this doesn't have any cuff, and it easily just it does not need practice and learning curve. You can just directly place it and it will sit over the larynx, and anyone can use it for emergency securing of ventilation. So these are available in various sizes. So this is the color coding above IGEL. So for a normal adult, we use yellow size IGEL, and for a large patient we use green. So green and yellow can be used, and for a heavy patient we use orange sized IGEL. So here we need not inflate cuff, and moreover it has a provision to pass suction catheter and remove gastric secretions also. Then medications. What medications we have to keep in an intubation kit? We require two types of medications. First is induction agent, which makes the patient deep, which gives anesthesia to the patient, and the other is muscle relaxant, which opens up the vocal cords to facilitate intubation. So commonly used induction agents are propofol, etomidate, and ketamine. So normally if BP, hemodynamics, heart rate, and they are all stable, for example in a neurosurgery patient who has poor GCS, you have to intubate, then you can take propofol. But in a trauma patient or in any cardiac patient where BP and heart rate and all are unstable, then you have to take etomidate and ketamine. But all these drugs should be there in intubation kit. Then muscle relaxants. Muscle relaxants for immediate intubation, succinylcholine and rocuronium are the drugs of choice. So succinylcholine is always the drug of choice for any easy, difficult or any kind of intubation in an emergency and ICU scenario. Unless the patient has burns, there is no other absolute contraindication for this succinylcholine. This is given at the usually for an adult 100 mg we give 1 to 1.5 milligram per kg. So usually for an adult 100 mg 2 ml of succinylcholine directly by rapidly giving bolus we give succinylcholine. And immediately within 30 seconds patient will be relaxed and we can intubate. And rocuronium. And this action of the succinylcholine lasts only for 1 minute. After 1 or 1.5 minutes, patient will come out. That is the reason this is the drug of choice, because if you are not able to intubate or anything, patient will come and breathe spontaneously. And this is rocuronium. This also will facilitate intubation within 30 seconds to 90 seconds. But the duration of action is very much prolonged. So if the airway does not seem to be difficult, then we can give rocuronium. So these two are the drugs of choice if we have to intubate a patient rapidly. Otherwise, vecuronium also can be used for maintenance or if we have time to intubate and all. Then Stellate, bougie and tube insertion. So this is gum elastic bougie, which has got a 45 degrees angle at its tip. So when we are not able to pass a tube, so this is stiff and small 5 mm sized airway introducing catheter. So by this, even if the larynx is anterior or something, we can just introduce by this and railroad an ET tube over this. After doing laryngoscopy, if there is difficulty passing tube, then we can always take a bougie, then introduce in the vocal cords. After that, under vision. After that, we can introduce a tube through this, and once that this tube is inside vocal cords, we can remove bougie out. So by this we can facilitate intubation, but usually these bougies are hard and even soft bougies also will cause airway trauma. But when we have difficulty, they should always be a standby. Then we have stellate. Stellate and bougie are two different equipment. So this is a bougie and this is a stellate. Stellate is more stiffer and stellate does not have any angulation. So for stellate, what you have to do is, suppose this is a stellate. First only you have to pass this stellate inside, because it is a stiff structure. You have to bend this stellate, so it will increase the curvature of a tube. So when you're not able to pass, you can just make it manipulated, because it is bougie, it is not bending. If it is a stillet, it will bend, and then you can facilitate intubation and remove that stillet out. With bougie, it is not possible to increase angle or anything. You can just use it as a maneuver to pass a tube. So these are the additional airway equipment to make intubation easier. Then how securing endotracheal tube. Prior to intubation itself, we have to make sure that for securing also all the equipment are there. So we have to keep tapes which are cut at around 10 centimeters length. So this is an adhesive tape method of securing an intubation tube. So one tube should go above the maxilla and fix over the mandible. One should go around mandible and fix over the maxilla, so that the tube is secured in place. So this is with the help of tapes. The other method is bandage technique. We can use a bandage and fix the ET tube when we cannot use adhesive bands, such as when patient has beard and all. Then oxygen delivery devices and ventilation. So these include face mask, Bain circuit, oral airways, ambu valve. First, this is the transparent face mask. So this is the various sizes of face mask should be there. So first we have to keep over the patient and see if this is fitting over the patient. So this should be above a patient's nose, and this lower end should cover the patient's lower end of mouth. This should not come beyond the jaw like this, because there will be leak. So this triangle should fit the triangle of nose and the lower and the mandible, so that there is a, first we have to check the size and use appropriate sized face mask. So then this is ambu. So to this port we have to connect it to the oxygen delivery device, either anesthesia machine or a flow meter, wall mounted flow meter, and we have to put oxygen around 7 to 10 liters. Then this is meant to facilitate reservoir bag or exhalation. So first we have to check whether there is no leak. So we can, this is the valve, we can close this valve. Now there is no leak. So, but this much, when there is no leak, it is difficult to ventilate a patient. So we have to open it a little. Then we have to facilitate how much this is required. But if all the oxygen we are giving is getting leaked through this valve, then it is defective and we have to not use this ambu valve. So we have to check this ambu, connect it to the mask, and then connect it to oxygen port, and then facilitate intubation. Other method is using Bain circuit. Bain circuit is this is where we have to connect to mask. This is the bag which has a valve. So depending on the leakage through the patients, we can close this valve or open this valve. And we have to use this to connect it to some oxygen delivery device such as flow meter. And this is how we should ventilate. We have to close this and oxygen goes in this way, and inside, from the green tube inside, it is exhaled and it goes out through this valve. So when patient is not breathing, we can close this valve and ventilate a patient. And when patient is spontaneously breathing, we can completely open up this valve. This is the oral airway. So there are various sizes. For a normal adult, yellow or orange airway you use, and for a small adult we use green sized oral airway. And before using, we can measure the size. We can from the angle of mouth to tragus of the ear, whichever airway is fitting, that airway we have to use for the patient. We have to apply a gel so that it does not injure the oral cavity, and then we have to introduce it. This oral airway is used when we are not able to, especially in elderly geriatric patients, where always there is a leak in the mask because of loss of buccal pad of fat. So in that patient, if we use oral airway, it directly facilitates flow of gases to the pharynx. So in that way, leak can be reduced and we can ventilate a patient. So this should always be there in an intubation kit. So overall, there is a face mask, oxygen tube, airways, reservoir bag, ambu bag. Then suction equipment. There are two types of suction. One is Yankover suction and another is suction catheters. This is a suction catheter. Always when we are for normally we can use a white color 14 or 12 French suction catheter, but if we are using this to inside an endotracheal tube, so we have to see the tube is 2 times the size of endotracheal tube. Suppose the patient has 5 size endotracheal tube, we should use a catheter less than 10 French suction catheter, or else any size will facilitate oral suction. And Yankover suction catheter, this is nowadays used mostly because this has a smooth tip. So because this suction catheter can usually suck in the mucosa also and damage mucosa. That's why Yankover suction is nowadays used. Unless you have to pass this catheter deeper into the pharynx and do suction, we can use Yankover suction. So these are the 2 types of suction which can be used. And this is a connecting tube for wall mounted suction or any suction equipment. Then this is lubricating gel. Always before placing a Ryle's tube or intubating, we should have a lubricating gel, so that there is no, we have to spread that gel over the cuff of endotracheal tube, so that the gaps between the cuff are filled up with this gel, and also there is some analgesia to the mucosa, so that the mucosa does not get damaged. So these are the equipment which are required for intubation. So the summary of equipment which should be there are, so first, appropriate size endotracheal tubes, laryngoscope and blades, syringe and medications, stylet and bougie, securing devices including tape, oxygen delivery equipment, suction equipment, personal protective equipment like gloves, and if in COVID, when we are using in COVID patient, other suction, personal protective equipment, and sterile lubricants like jelly. In addition to all this, we have to keep ready ventilator and tubes, and including settings for that particular patient. Emergency drugs. In an emergency crash cart, what are all the drugs which should be there? First is life-saving drugs, then cardiac drugs, respiratory drugs, CNS drugs, GI drugs, obstetric medications, anti-allergic drugs, and analgesics. All should be available in an emergency drugs. So what are all the life-saving drugs? Adrenaline, atropine, adenosine, aspirin, amiodarone, which is also called as cardarone, then lignocaine, and sodium bicarbonate. These are all life-saving drugs. So epinephrine. Epinephrine is given in cases of cardiac arrest, anaphylaxis when there is severe hypotension and bronchospasm. So 1 ml of epinephrine, that is 1 ampule of epinephrine, has 1 mg, that is 1 ml of epinephrine. So that we usually dilute in 10 ml syringe. So that will make it as 1:10,000 dilution. If we take 1 ml from that and again load in another 10 ml syringe, it will make, we'll get 1:1 lakh epinephrine. And in surgery cases, sisters know, in 100 ml we take 1 ml, so that can be, that is 1:2 lakh adrenaline. So in emergency situations, we usually use 1 mg or 1:1000, that is 100 micrograms of adrenaline. Then atropine. Atropine ampule contain 0.6 mg of atropine. So it is used when there is severe bradycardia or there are lot of secretions, such as in a patient with OP poisoning and adenosine. When the heart rate is above 150, above 200, we use adenosine and aspirin. Aspirin tablet is given when patient is having angina and myocardial infarction that is detected in ECG where there are large ST elevations. So a dose of 300 to 325 mg aspirin is given orally initially. Then amiodarone. Whenever the ECG shows large QRS complexes, broad QRS complexes and irregular, and when the BP is on lower side, then we give adrenaline. But when this broad complex ECGs, QRS complexes are associated with there is no BP or the BP is less than 50, then we can give use defib and give shock. But if the BP is above 50, then we can use amiodarone. So first 150 mg, that is 1 ampule of adrenaline contains 150 mg. Directly 1 ampule can be diluted in 100 ml and can be given over 20 to 30 minutes. Then lignocaine. Lignocaine, all of us are well versed with lignocaine ampule. So 1 mg or 2 mg per kg of lignocaine can also be used when there is broad complex QRS complexes in ECG and heart rate is above 150 or 200, then we can firstly give lignocaine. Sodium bicarb. Always when there is acidosis, severe acidosis in EBG, then sodium bicarb can be given at the rate of 1 milliequivalent per kg. Then dextrose. Often in emergency scenarios, we all know that usually common scenario is an alcoholic patient coming in an unconscious state who just get up after giving dextrose. And also in pediatric patients, they often come in unconscious state just because of hypoglycemia and they just get up once we give dextrose. So always dextrose is one such drug which is simply we can reverse a patient. Then cardiac medications. These cardiac medications include norepinephrine, dobutamine, dopamine, vasopressin, nitroglycerin, diuretics, furosemide, torsemide, then digoxin, then metoprolol and esmolol. So norepinephrine. Norepinephrine, 1 ampule contains 2 mg. So this is used in case of severe hypotension. Then dobutamine. Dobutamine, each ampule contains 5 ml, which is 250 mg. That is diluted in 50 ml and can be kept as an infusion, especially in patients with heart failures, any cardiac condition which is causing hypotension. Then dopamine also same. Then vasopressin. A patient who is not responding to norepinephrine and he is having severe hypotension, then vasopressin can be used. So 1 ml of vasopressin is diluted in 40 ml and can be kept at 1 to 2 ml per hour. Then nitroglycerin. Nitroglycerin when BP is 200, 170, that can cause cardiac Yes, ma'am, I'm telling that.
So if you have any doubts, you can ask.
You can ask. So nitroglycerin, uh, 25 mg. It is a 5 ml ampule. It is a 5 ml ampule which contains 25 mg of nitroglycerin. So it is diluted in a 50 ml syringe, and it can be kept titrated according to the BP. So it can be immediately used. Or sublingual GTN. This is available in 0.3 to 0.6 mg. Whenever there is angina, whenever there is myocardial infarction and ST elevations, along with aspirin, sublingual GTN, that is nitroglycerin, can be given. Otherwise, in other patients, when there is severe hypertension, BP above 170, we can use nitroglycerin. Then furosemide and torsemide. A patient with acute myocardial infarction who comes with pulmonary edema, with Krebs, with the frothy secretions coming out from the mouth and ET tube, for them, along with norepinephrine, dobutamine, diuretics are also very important. And also in hypertensive emergencies, when the BP is above 200, then also we need diuretics. So furosemide is usually used. The dose is 0.1 mg per kg, usually 20 to 40 mg of furosemide, that is Lasix, we use. The other commonly used drug is torsemide, which is nothing but Ditor. So Ditor doses, even a patient is taking suppose 40 mg furosemide or Lasix, we can give 20 mg of Ditor, half the dose of Lasix. Then digoxin. Digoxin is not just given unless prescribed, but when heart failure is associated with atrial fibrillation and patient is already taking digoxin before that emergency situation, then we can give IV digoxin to just control that heart failure and atrial fibrillations. So 1 ampule we can take and given in some 100 ml and give it over 20 to 30 minutes. That is called rapid digitalization, and all these symptoms will get controlled over 1 hour or 2 hours. Then metoprolol. When the heart rate is again more than 150, 120, and if you want to control heart rate but if you don't want to get down BP, you have to maintain BP, then you can use metoprolol. So 1 ml contains 2 mg of 1 ampule. 1 ml contains 1 mg of metoprolol. So we have to dilute this 1 ampule in 10 ml syringe, and we can give 0.5 to 1 ml, that is 0.5 mg to 1 mg of metoprolol. And depending on the control of heart rate, we can again give additional doses. So esmolol. Esmolol is more rapid acting than metoprolol, but esmolol also causes decrease in BP. So esmolol is used when the tachycardia is causing severe hypotension, and as an emergency we have to control heart rate. So esmolol is available as a vial. So 0.5 mg per kg is the loading dose. Then respiratory drugs. Respiratory drugs are aminophylline, deriphyllin, steroids like hydrocortisone, dexamethasone, then meteor dose inhalers and respules like Duolin, Budecort, then acetylcysteine, which is Mucomix. All these are respiratory drugs. So deriphyllin and aminophylline IV are used for severe bronchospasm in bronchial asthma and COPD. And dexamethasone 4 to 8 mg IV or IM can be given when there is urticaria, allergy and asthma. And hydrocortisone is an emergency drug whenever there is status asthmaticus. When a COPD patient comes with acute desaturation, bronchospasm, immediately we have to give deriphyllin, hydrocortisone, because in such a severe bronchospasm state, they cannot inhale these respules and meteor dose. Inhalers will not act because it will not go inside because of bronchospasm. So we have to give IV cortisone and deriphyllin. So cortisone, 1 vial contains 100 mg. So we have to dilute it with 3 or 5 ml normal saline, and we have to give slowly over 5 minutes. Suddenly if we give, it will cause hypotension. Then acetylcysteine mucomix. When the patient is not able to cough, then we can give this mucolytic. And respules, Duolin contains levosalbutamol and ipratropium bromide and budesonide. So when a patient comes with severe asthma or when there is bronchospasm, so we can use these respules. But when it is severe enough, then we have to go for IV medications. Any doubts regarding this drugs? Then I will come back.
How many have used these medications? Just ask how many have used this medication. How to reconstitute that, what you said, no? Reconstitution of 5 to 10, 2.5 to 10 milligrams per kg body per minute. How to calculate that? Can you enough you share how to calculate that? You can randomly call someone and make it more
Can you?
practical, interactive session.
Can anyone tell how do you reconstitute dopamine, noradrenaline, anything, whatever? Any cardiac drug, either norepinephrine, dobutamine, or dopamine.
You make it another column how many it comes in the vials or ampoules or one contain how many milligrams.
Okay, ma'am.
No, practically you should
Yes. Dopamine comes also in 5 ml. 5 ml contains 200 mg. We get it in ampoules or vials. Norepinephrine is usually noradrenaline. Usually we get a vial with 2 ml. 2 ml contains 2 mg. Dobutamine and dopamine, either ampoules or vials, anything is available. But 5 ml. 5 ml contains 250 mg of dobutamine and dopamine 200 mg. That we have to dilute in 50 ml. So how much 1 ml contains? 250 mg in 50 ml. So 1 mg contains how much mg? 5 mg. So 5 mg is 5000 micrograms. So if suppose 5 micrograms per kg per minute, you can calculate over your phone. Suppose you take a 50 kg patient and you can calculate. Take 5 micrograms, 5 into 50. Into minute kada, 60 into 60 minutes is equal to 1 hour. So ml per hour we give for infusion. So 5 into kg. Suppose you take a 50 kg adult and this is minutes. For an hour if you have to calculate, then suppose dobutamine is there, 250 mg we have diluted in 50 ml. So 1 ml contains 5 mg. That 5 mg is equal to 5000 micrograms. Okay. So now comes the dose, how much we have to give. Suppose this is 2.5 microgram per kg per minute. You take 10 micrograms per kg per minute. So how much dose we have to give for a 50 kg adult, you have to calculate. So this is 10 micrograms into 50 because it is a 50 kg adult into 60 because we have to give it in ml per hour infusion. This is minute dose. So how much you are getting? 30,000. So 30,000 divided by 5,000. 6. So we have to give it at 6 ml per hour. That is the dose.
Got it? Did you you understand this concept? Yes? Okay, similarly explain the other one. Vasopressin, 50 kg man is there.
Yes, for a 50 so 40 units of each ml or each ampule of vasopressin contains 1 ml. 1 ml is total of 20 units of vasopressin. So we have to take either 20 units in 40 ml or 2 ampules, 40 units in 40 ml. So 1 ml contains 1 unit of vasopressin. So if we usually standard doses in such a dilution we give 1 to 2 ml at a maximum of 4 to 5 ml per hour. Beyond that we don't reach. In the dose which I am showing 0.1 is the highest dose. Usually we keep it 0.01 to 0.02 per minute. 0.01 into 60 is 0.6 units per hour. So 0.6 units per hour is around 0.6 ml. So if you take a dose of 0.02 units per minute, how much ml per hour you should give? 1. In a similar way, in DG.
So you just tell them how much ml contains how many milligrams of nitroglycerin. Let them calculate how many.
Okay. 25 total 1 ampule contains 25 mg of nitroglycerin. That we will dilute in 50 ml syringe. So 1 ml contains how much of NTG? No. 25 by 50. 25 divided by 50.
25 units, 1 vial. You are diluting with them 50
50 ml.
Isn't it? So 1 ml is equal to how many units?
0.5.
0.5 units. Okay. Okay. Now calculate. I am 50 kg man. 50 kg, huh? So
Yeah.
then 50 kg man. So with this 0.5 to 2.5 per kg body weight per minute. Okay, 50 it is 50 kg into 60. So
0.6.
50 into 60 is 300, no? 300. So
300 into
60. So 1 ml contains now 0.5, isn't it? Now 0.5. You got lost, no?
yes. This is micrograms.
Micrograms.
Yes, ma'am. 0.5 micrograms per kg per minute. 0.5 into 50
0.5 to 50 into 60.
into 60.
This comes around. Calculate.
60 into 50 is 3000.
1.5. So 1.5 ml.
Per hour. Per hour.
Only 1.5 ml. You can give that much, huh? Huh?
Dose, if we can.
60 into 50 is equal to divided by 0.5. So 2.5 ml per hour. 2.5 ml. So we can give 2.5 ml per hour. Okay. They have to calculate that actually. Calculate that and give.
So depending on the control of BP, then we can titrate ml. This just gives an indication of approximately how much ml we have to give. Then CNS medications. A patient with seizures, when a patient suddenly has seizures in an ICU, then what drugs you have to load and give? So for the immediate control of seizures, we can give midazolam. Midazolam we can give 1 ml contains 1 mg of midazolam. So 1 mg or 2 mg of midazolam we can give for immediate control of seizures. Then we have to give Eptoin. Eptoin, how much one ampule contains? 100 mg. So around 15 to 20 mg per kg until 50 kg adult low. How much of Eptoin we have to give? 1 gram, 1000. And with 10 ampules we have to load. That 10 ampules we have to give it in 100 ml. Slowly we have to give in 100 ml NS because Eptoin causes severe hypotension. So another drug which does not cause hypotension is Levipil. Levipil also in the same dose we can give, but it does not cause hypotension. And mannitol. When we have to give mannitol? 100 ml we can in 50 ml of mannitol, 50 to 100 ml of mannitol slowly we can give when a patient is having a tumor in the brain or when there is a trauma and suddenly patient throws seizures or patient suddenly becomes drowsy, unresponsive. Then to raise the intracranial pressure, then we have to give mannitol. Then GI medications. Suppose a patient comes with renal colic or abdominal colic in the night to an emergency department. At that time we don't give dopamine, dobutamine or something. At that time, for immediate control of pain, only thing we have to give is antispasmodics. So what all antispasmodics we should have in emergency card? Commonly we use Buscopan. So that is given in a dose of 20 to 40 mg IV. Other than that, Drotaverine, metoclopramide or ondansetron antiemetics. Ondansetron, 1 ampule contains 4 mg of ondansetron. So maximum we can use 2 ampules. Then metoclopramide, that also we can use in especially when ondansetron is not available and there is a risk of regurgitation, such as in patients with renal failures, those who have high risk, then we can use metoclopramide. Other than that, if patient is having GI bleed because of gastritis, peptic ulcer, and high dose of medications, antibiotics, then we can give pantoprazole. So Pantop 1 vial contains 40 mg. That will dilute and give. Then obstetric medications, mainly methergine to stop postpartum or uterine bleeding. So 1 ampule contains 0.2 mg, which can be given IM or IV. And then emergency, a pregnant patient comes with BP above 170, 200, then labetalol is the drug of choice. So labetalol, so this is 4 ml of labetalol, which contains 20 mg of labetalol. We have to dilute this 20 mg in a 10 ml syringe. So 1 ml is equal to 2 mg. So we should directly give 4 mg to 10 mg of labetalol. Then magnesium sulfate. When a pregnant patient has hypertension, BP more than 170 or having seizures, so initial drug of choice is magnesium sulfate and we have to control BP with labetalol. Then tranexamic acid. A bleeding patient can be given tranexamic acid. Anti-allergic medications. So, a patient having skin rashes, itching, bronchospasm because of reaction to any allergen or during blood transfusions or after giving an antibiotic or for any drug allergy or antibiotic allergy, or a patient comes from outside with all the symptoms of allergy. So first thing commonly we give Evel and Hydrocort. Evel, you are better people to tell us how much of Evel and Hydrocort you give. And Evel?
25.
IM or IV we can give. And if there is severe reaction which is causing severe hypotension, bronchospasm, then we have to give epinephrine, which is 1 ampule of epi.
Madam, excuse me, I have one doubt, madam. Even the hydrocortisone place లో మనం ఒక్కొక్కసారి డెక్సా కూడా ఇవ్వచ్చు కదా?
డెక్సా కూడా ఇవ్వచ్చు, కానీ డెక్సా కొంచెం లేట్గా యాక్షన్ స్టార్ట్ అవుతుంది. సో ఇమ్మీడియట్ యాక్షన్కి we prefer hydrocor, but alternately we can use dexamethasone. So this is adrenaline. 1 ml contains 1 mg. That we have to dilute in 10 ml. So we can give. So each ml contains. ఇప్పుడు ఎంత 1 mg is 1000 micrograms. So each ml contains 100 micrograms after dilution. So 100 to 200 micrograms we can give if there is severe hypotension, severe bronchospasm, which is due to allergy. Many times we face this when all these reactions when we are giving some drugs like propofol or some muscle relaxants or some IV fluids. So, thank you. Yes, ma'am. If you all want to discuss further regarding any of the drug or intubation kits, we can interact.
I think these are all, you have been doing this, you have been seeing these medications and you have been practicing all these, practically giving all these medications in your day-to-day practice. This is just a reiteration. So, I mean, you can just have 2-3 examples of it, go back to those because most important thing is you have to know how many milligrams per kg body weight, and because you most of the time doctors write 10 milligram per kg body weight. You have to calculate, you should know how to calculate and give it. Okay, so can you go back to few of such examples? Next give is you prepare a wonderful chart. Chart of how many what is the drug, what is the action of the drug, how many gram per kg body weight per minute, and what does that mean? It comes in ampoules or vials, and how many milligram, how many ml, and each ml contains how many. So can you all prepare with a chart and put it in your ward or the area you are working? Yes? Okay, beautifully designed, and then you can put that. Will actually you will get to know. You will have immediate cross reference also. You will have it in your ward. Okay, you just have explained in this also. You take few examples and let them answer. Okay.
So, suppose a pediatric patient whose weight is 10 kgs comes in heart failure with frothy secretions and frothy secretions and BP is low. So you have to give a diuretic. Suppose give Lasix or something. So how much dose of Lasix you want to give to that patient? Weight of the patient is 10 kgs.
1 mg.
1 mg of Lasix.
How frequent you can repeat that? Is it it's a infusion?
Twice, thrice, or 4 times also we can repeat. In an adult, maximum dose is above 6, we have to limit it. 120 is the maximum dose. But in pediatric cases, 2 mg, 0.2 mg per kg, 0.3 mg per kg, 0.4 also is given unless the symptoms reduce. Until the
It's a stat
symptoms-
dose or it's a infusion?
And stat dose infusion also can be kept at 0.1 mg per kg per hour. And norepinephrine. How do you dilute norepinephrine? See, each ml contains 2 ml. Each ampule contains 2 ml of noradrenaline, which is equivalent to 2 mg. So 2 mg you dilute in 50 ml. So how much 1 ml contains? Point one. 2 mg divided by 50 ml. So each ml contains 0.04 mg, which is equal to 40 micrograms. So 1 ml contains 40 micrograms.
So 50 kg man, you want to give it as 0.05 micrograms.
Mm.
How much you should give? 50 kg.
So 0.05 micrograms per kg into 50. You have to give it at 0.05 micrograms per kg per minute. So 0.05 into kg is 50 kg per adult
1.2.
into 60, because we have to give it at hour into 60 minutes. So 150. Total is 150. 150 we have to divide by 40. 1 ml contains 40 micrograms.
3.7.
That much ml per hour is the infusion rate.
Okay, got it? Next example. Any other example? Epinephrine.
Epinephrine dilution. How do you dilute epinephrine?
1 terminal of solution.
That is 1:10,000 dilutions. As such, the ampule of adrenaline contains 1:1000 dilutions. It is written over the ampule. So it is written over this ampule, 1:1000 unit. So if you dilute with 10 ml, 1:10,000.
10,000.
From that, if you take 1 ml and dilute again in 10 ml,
1 lakh.
it is 1:1 lakh.
1 lakh.
So anyone can list out equipment for intubation. No, for a 30 kg, for a 30 kg male patient. 6 tube ane kaadu, 6, 5.5, 6.5. Now 3 sizes we have to give.
One size less or
One size more. Okay, that is tube. Then Booji.
Lubricants.
Face mask.
Suction capsules.
And
Tubes.
and what size of blade you are using? You have to check for the size. Suction catheter, suction equipment, gloves, drugs. How do you load scoline? Or rocuronium, any muscle relaxant, whatever you are everyday loading. How do you load?
Rock 1 ml 50 mg direct 1 to 2.
5 ml contains 50 mg. So for a 50 kg, 1 mg per kg. If a patient is of 50 kg, give 50 mg. 100 kg, then you have to load 2 vials, 100 mg. 30 kg, 3 ml is sufficient. That is rocuronium. And succinylcholine, usually for adults, 100 mg, that is 2 ml. And securing tubes. Anything else you want to discuss? Anything else?
Okay, so homework for you all is prepare the checklist and come with a printout. You have to show me the printout, and the same thing you are keeping in your ward. Okay? The emergency dress, whatever is there, hang that in front of that emergency dress so that you can have a checklist. The moment daily you go to your duties, first check whether all these medications are there or not. Okay? And all this equipment is the intubation kit is there, whatever you have told now is there or not. Okay, that's your first job. Okay? Fine? Is agreed?
Thank you, ma'am.
So we'll close the session.
Checking, ma'am, once check, as madam said, checking the intubation kit and emergency drugs in a cash cart is not only responsibility of a nursing staff but also the in charge whoever is working, the doctor and technician.
How we
working
have
there.
to check the tube is in position or not?
No, we have to check.
Not telling about the position, we are just checking about the equipment. Whether equipment is there or not. You
In a
have to
crash-
verify that all the, you have the crash code in your ward. You have to verify that everything is there on its checklist
Then
for
why
the
you want
verification of the
to-
equipment.
Why you want to check with the stethoscope if it is in position?
We are not talking about the position of that class is over. This class is for whether you have the equipment in your ward or not. Okay? It's not in the body, patient body. It's in your ward. If you are, when your response, you are working in your ward, no? Which ward you are working?
Theatre.
Huh?
Operation theatre.
Operation theatre. So that's why. So once you go into the ward before doctor comes or patient comes, you should see that everything is there. Otherwise, doctor will say, give this one. Tube, ET tube, so size this. You'll be very, so you have to check. This is checklist for you to verify whether it's there or not. Okay?
Ma'am, this class is a very good and very important. We know very well so many things. Thank you very much. But a small doubt, madam. Till now, I didn't hear the option of endotracheal tube which can be used. That you told that IZ is the best. One another option for intubation. Are we using that in operation theatres or in emergencies? If we have, let me see clearly
In
either picture or it is
In
a live one.
ICUs and operation theatres, we have.
As well,
I think in emergency intubation, I don't know.
What condition it is used?
Ma'am, when we are not able to ventilate or we are not able to intubate a patient with an endotracheal tube, then simply a laryngeal mask airway or iGel can just be inserted. It will just sit above the larynx and we can connect a vein circuit or ventilator and it will ventilate patient.
This is only temporary before we get
Yes.
Yeah, before
Yes,
we
yes.
get an access or else before proceeding to tracheostomy in a difficult airway, we can use a laryngeal mask airway. Or anyone anyone can use. iGel is so easy that until a doctor comes, you can also just place it.
Later we'll see.